Dr. Gaurav Luthra just comes in with a name and a face and has traditional signature smile, and he is going to speak to us on cataract surgery in vitrectomy, gas and oil-filled eyes. Over to you, sir, for the next 7 minutes.
Hello. Thanks, Anurag, and it's nice to be in Vizag. Cataract surgery in vitrectomized eyes, they do pose challenges, and I get to do quite a few of them because we have an active VR setup in our place. So when it comes to cataract in vitrectomized eyes, there's been an incidence reported of 12.5 to 80%, and silicone oil seems to be one of the primary reasons, and gas tamponade the other. And then of course there is the occasional lens touch, and there may be PC feathering due to inflammation, and also lots of injections nowadays that we are giving. They're also inducing cataracts to many of these patients sooner than otherwise, and even may changing texture of the cataract may change as well. The challenges are basically biometry, which things have changed a lot with the advent of optical biometry, and we, in our setup at least, for all patients undergoing VR surgery, they do get a optical biometry done before they end up going for the VR surgery, and also after they've been operated, because there may be changes in axial length with belt buckles and everything. So before they go on to develop a cataract, routinely our retina surgeons would get a optical biometry done, just in case somewhere in the few years that they go on to develop a cataract. There are also the retinal pathologies which have to be looked into. Sometimes you may have oil or gas in situ. You have to decide what kind of anesthesia you would like to use. These eyes will typically have very deep chambers. Many of them will be highly myopic. There is the possibility of zonal laxity, and the capsule may not be very healthy either, and there may be difficult nucleus handling. You may be dealing with a floppy iris, and sometimes you may have insecure wound closure because many of these eyes remain hypotenuse. So many of these challenges, and then with biometry, as I said, the belt buckle, and also the fovea may not be entirely easy to detect. So many of these patients have very poor vision, and there may be opaque media, there may be oil in situ, especially if you're forced to do an ultrasonic biometry. So there are several options. As I said, we can do it before and after VR surgery. A sitting position may help sometimes when there is oil in situ. You can adjust the velocity. B-scan helps, but as we've realized now, it doesn't come anywhere close to giving us an accurate outcome. And a fellow eye biometry may help, but as we understand, the axial length may change in VR surgery eyes. And then of course, if you're totally at sea, you may consider doing this or coming back to do a piggyback, as was being discussed just now. So surgical challenges, they can be several. They may be coexisting glaucoma, oil bubbles in the chamber, endothelium may be compromised, rigid or floppy iris, difficult capsulotomy sometimes, and loose zonules. We've discussed few of these as well. So coming on to a couple of cases which I thought will make sense here. And you can see that a lot of oil there, which is okay. You can get this out just with pushing in viscoelastic. And once that is done, you can go and look at that peculiar cataract, and you can also see some silicone oil bubbles on the conjunctiva here. Sometimes they develop on the ports. And many of these patients, when you're operating under topical anesthesia, they cannot fixate well. So you may need to stabilize the globe. You can see there on the left, I'm using a globe stabilizer. And then of course, once all that is done, things become much easier, but then there may be flotation effect. This eye has oil in situ, and you can see that when there's oil, of course, some of it will keep finding its way from the zonules, and then also there will be a good flotation effect. And if you have to polish an eye with a PC plug with oil in situ, it does pose challenges. And while some surgeons would like to actually purposely do a posterior rhexis and drain the oil, I don't like to do it. It makes the surgery very unpredictable. The couple of times that I've done that, the oil sometimes comes out in, the size of the capsulotomy may be smaller, and then the oil may find it tough to come out. It may extend the posterior capsule tear in peculiar ways. So I don't like that route of bringing the oil out. I don't know if Anurag likes to do that, or anybody else over here wants to say that they like to do it that way. So once this is done, then of course PC polishing is good to do, because you don't want to do an early YAG in such eyes either. And meticulous, you have to spend time, you can manage, and then get away with a good surgical outcome in such cases. So there goes. It's good to keep maintaining the chamber all through, and I like to keep infusion on from my left port, so that if there is some silicone oil which is coming in from the zonular areas, it keeps draining out and doesn't preclude your view. So that done, the surgery is usually good to kind of, it's gratifying. Coming on to another patient with who rapidly developing cataract following VR surgery and referred to us. You can see that the PC looked a little suspect here on the femtosecond laser. We decided to go with femto-assisted surgeries. Many times these lenses which are opaque will be seen nicely on the laser, which is the OCT on the femtosecond laser, and comes out that you can suspect if there may be a PC break here. And this is an intumescent, typical intumescent cataract. So once that is done, you can of course set it up. You want to stay away from the posterior capsule, you can change the posterior offset a little bit. You can see that this eye was gas filled and the gas was still there. It was just 15 days after the surgery. This patient also had additional RK, multiple incisions, and had a rapidly progressive cataract, probably from a lens touch. So we were concerned about what may happen with the posterior capsule, and there was obviously gas in situ which was still to be absorbed. So a femtosecond laser here was very helpful. Many people think that in RKIs it's not a good idea to do a femto-assisted capsulotomy, but I like to do it. Even if you have some small tags of discontinuity, you don't get a runaway rhexis, and you can complete the rhexis. You can see the air bubble shining through there. It was challenging, and this was a fairly hard cataract. And the lady was very, very anxious and nervous throughout surgery because she had suddenly first had a detachment, and then after that she had developed a cataract. And so you can see the air bubble causing, the gas bubble there causing a lot of flotation effect. And I'm injecting in viscoelastic before bringing out my phaco probe. And there was almost no glow because of the effects of the air gas bubble there. Only when you tilt the globe to one side, you'll get to see the glow. So you have to operate without the benefit of retroillumination. And sometimes removing cortex in such eyes is challenging, especially with femtosecond laser cleaving the cortex just along the rhexis. It's sometimes challenging to do that. You'll probably just get to see when I move the eye to one side, that posterior with retroillumination, you can get a view of what it looks like under retro. See there, I'm moving it to one side, trying to get a view, and then the air bubble, gas bubble comes back in, and but you can check if you've left behind any cortex there. And once that is done, of course, then surgery becomes a little simpler, and you can go ahead and inject your lens. I like to use these preloaded lenses, like this one is the Hoya with the multi-cert, which doesn't require you to enlarge the incision, and you can inject the lens straight into the capsular bag. So in such challenging situations, and here I'm using this Herschel-Tuck cannula, which is really nice. You saw me hydrate the roof of the incision, the sides. In these RKIs, I like to do this. And you can see that in the left hand, I'm keeping the infusion on so that my chamber is always formed, and then going into the other incision. So it's quite a nice instrument, this, and it can, all four walls can be done, and then quickly check with trypan blue. So it is a little challenging, but can be managed. Do I have time to show one more quick 2-minute video? Yeah, okay. So this is actually a very short one. Here I'm trying to show that sometimes you'll deal with these silicone oil, cysts on the conjunctiva, and they can be irritating for the patient. Very easy to deal with. You just have to kind of make sure that you get a good, nice, deep puncture, and then with a bud or with something similar, you can squeeze out that oil, and patients do feel quite happy after this because they are unsightly and they also cause foreign body sensation all the time. So I typically would like to get them out. And so I think I'll stop here because there must be other speakers, and I'll finish off here with my last video. Okay, thank you.
Thank you so much, sir. I'm sure because of the shortage of time, you couldn't show even 10% of the plethora you must be having.
I did have a few more videos, but I thought, I've run out of time.
Tell me, talk to us through this. Usually these patients who've got vitrectomy done already, usually they present to us in a situation wherein the retinologist asks them to go for a cataract surgery. And by that time, you can have a host of situations. You can have the pupil non-dilating, but what is more important is if it's a very hard cataract, it's a dense nuclear sclerosis, and even the VR person is not able to tell you with concrete authority that there has been an instrument touch in the posterior capsule or not, what would you do? Or what would I do? Because I am a standalone practitioner. I don't have a vitreoretina assistants with me. So what should I do?
So one thing is that usually, like my other patient where I thought there was a lens touch, but luckily we got away without anything going on. But I have dealt with a few patients where there was a lens touch or there was a suspicious thing because there was a rapidly progressive cataract. So there, you would have to use all the skills of some one talk, which I heard you give in the other hall just now. Low infusion and low parameters, and I love to do that. I also operate around 30 to 40 bottle heights, and we have a master there who can fill in with us. Srinivas has just taken the mic because he wants to tell us something. He's the VR surgeon who can tell us a few things, but I typically would work at low parameters. I would always be prepared. I would be very careful doing a hydrodissection. Even if I did, I would probably do a hydrodelineation if it was a really soft one and create an epinuclear shell. So it's like it would probably work something like a scaffold, and I would just remove the central hard chunk of the nucleus first and then attack the, just like you do with a posterior polar pre-existing rent kind of a situation. That's how I would deal with it. And then of course hope that, and then there's been one instance which I'll never forget. I did a good capsular access, a similar cataract, went in with the infusion. These were the days like maybe 10, 15 years back when we used to work with 100 centimeter bottle heights. It was a high myope. The moment I entered inside and switched on the fluid, the whole nucleus went through and sank in 1 second. It was gone. So I think that's the benefit of using a low infusion and low parameters, and kind of inflate the chamber slowly, very gently, and don't let it suddenly expand big time, so that the lens iris diaphragm doesn't kind of go back suddenly. That can cause problems.
Fundamentally, what you're saying, I completely agree with you. But the only exception where I actually increase my fluidics a bit is the gas-filled eyes. I think they are
of course,
very non-compliant. They always keep pushing it forward, and
agree.
you
but
have
that
to
you
have
can do during the course of the surgery. You'll realize that that's happening, and you have an intact posterior capsule, because otherwise the gas would have come out. And once you're sure that it's there, then of course,
Thank you so much, sir. We'll let you go. Yeah, Srinivas. You're the next speaker. Why can't you speak from the other rostrum?
Here only
But
he's
you will
connecting.
use the same podium. All right.
Just one question I had. First of all, beautiful video you showed that when you are doing the cataract removal and the IOL implantation in a patient, especially who has a gas.
Yeah.
And
Right.
I didn't see any chamber collapse, nothing. It was
Absolutely.
just steady still as like a normal patient. My another question is, what was the urgency to do the cataract surgery? You could have waited for the gas to go away, or you could have even used a vent and put off the gas. If already the tamponading effect has been completed, then you can always put it a vent, remove that. It would have been little more easier rather than tilting and getting the reflexes.
Right.
But I should really admire, that was a beautiful surgery.
So this lady, as I said, she was a bureaucrat. She was very kind of anxious. She was anxious to get quick visual recovery. She literally pushed our retina team that following, she had, and as luck would have it, she had a rapidly progressive cataract for no reason. We didn't
So how did
understand.
you calculate the IOL
what
power
happened.
in that case?
We do optical biometry before we put up our patients for VR surgery as a routine.
So
all our refractive surgery patients and all our VR surgery patients get an optical biometry as part of their workup. So we had access to her optical biometry, and she was literally I was pushed to operate her on a non-scheduled day because she was not ready to wait for her cataract. Not that she would have seen anything after the surgery, because the gas would have still allowed her to, but
yeah,
at least
it's a long-acting gas.
sometimes you have to kind of cope with these demands as well.
So of the limited experience that I have, Srinivas, the urgency actually doesn't come from the patient, it comes from you guys, the vitreoretina guys who don't want to wait. But I completely agree with you, because both the anterior and the posterior capsules are virtually glued together, and he was implanting the IOL under BSS, so that makes it even better to